So welcome to this program entitled Caring for Women Across the Reproductive Lifespan. I'm Dr. Bove from the University of California, San Francisco, and I wanted to thank the organizers at the CMSC for putting on such a comprehensive program despite all the current challenges. A note from CMSC about accreditation and credit designation. So the CMSC is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing care and education for the healthcare team. And here are my disclosures. So the learning objectives for today. At the conclusion of the session, I hope you'll be able to discuss special considerations when counseling women with MS in family planning, review the impact of pregnancy on MS disease activity, review the most current evidence associated with disease-modifying therapy in women at all stages of reproduction, and employ strategies that support effective family planning communication and shared decision-making with women living with MS. And we'll go all the way from adolescence and young adulthood through family planning, planning a pregnancy, and then through menopause and healthy aging beyond the menopause. So first, to start off with adolescence and young adulthood. So we'll start off with a case. This is a 15-year-old girl with MS, and she's planning to start MS therapies. She had her period at age 11. Her menstrual cycle stabilized around age 13. She was diagnosed with MS 3 months ago, and she plans to start fingolimod based on the paradigm study. Now her questions for us are, I got my period at a younger age than my friends. Does that have something to do with my getting MS? Why do my numbness and my headaches fluctuate with my menstrual cycle? And can I start the pill? So first, a little bit about puberty and MS. It's been shown that there's declining age at first menses, at menarche, in girls in Western civilizations. And earlier puberty is actually a risk factor for MS and a risk factor for earlier onset of MS symptoms. After puberty is when we see the female to male ratio in MS really increase. And it suggests that something about sexual maturation may stimulate the immune system to become more towards the MS inflammatory demyelinating picture. And what are the mechanisms for this? Some postulate that an earlier age at puberty really reflects prior exposures, so maybe prenatal exposures, childhood adiposity, and other factors. Others postulate that actually the sexual maturation itself with the hormonal changes may actually trigger inflammatory events. And it's possible that both of these mechanisms are at play. So many of our patients do report menstrual fluctuations. So there are common complaints in the clinic that the MS symptoms kind of seem to peak and trough with the menstrual cycle. The research evidence is to date still quite limited. There are a few small studies that have suggested some fluctuation in these symptoms. And what may be the mechanisms here? Some have postulated cycling body temperature may actually exacerbate symptoms. Also cycling immune or neuronal activity tied to the reproductive cycle, perhaps the vascular changes as well, endothelial function. And it's possible that continuous oral contraceptives, so given over a period of 3 months as opposed to monthly, may actually stabilize symptoms in some women. This has been reported in the general population of women who experience migraines and may help some women with MS as well. So when we encounter a woman of childbearing potential, so all the way from menarche to menopause, at every encounter, we're really encouraging MS clinicians to ask, are you planning to become pregnant in the next few years? If a woman is indeed planning to become pregnant, it's important to discuss the implications for DMT selection and use. If her response in the current visit is no, it's important to ensure effective contraception. So what do we mean by effective contraception? Here are the sort of CDC guidelines and guidance on family planning methods. And just to note that methods that rely on behavioral such as taking a daily pill or inserting a diaphragm or a ring, or using a condom, are not as foolproof as long-acting reversible contraceptive methods such as intrauterine devices. And so if you're dealing with an adolescent population where healthy behaviors have not been completely established, it may be worth considering an IUD as opposed to an oral contraceptive as a more effective means of contraception. So back to our patient, she has no immediate childbearing plans. Recommendations to be followed up with the primary care physician. It's not typically our role to prescribe these medications, but we can certainly advise on their relative utility in women with MS. Consider a long-acting reversible contraceptive like an IUD, or also consider continuous oral contraceptives if her menstrual fluctuations and symptoms are severe. And it's also important to counsel at every encounter about the possible risks of fingolimod or any DMT to pregnancy. So if we move on a little bit in years to pregnancy planning. So here's our patient number 2 who's planning a pregnancy. So she's a 33-year-old woman with MS. Her first onset was in 2008. She did fulfill criteria back in 2010, but her real second attack was in 2013. She was started on fingolimod, and now she's married and planning her first pregnancy. So in our MS center, as in many other centers, we actually have a comprehensive approach to pregnancy management, and our principles are really shared decision-making and also individualized management. We typically recommend scheduling 3 visits when sort of thinking about a pregnancy. The first is a pre-pregnancy planning visit where topics will include MS management, general care such as following recommendations for folic acid, vitamin D, and smoking cessation, fertility considerations, so when to stop the contraceptives if those are being used, and is the woman going to need any fertility help, and then anticipatory guidance about support and time off work. We then recommend a second visit further along once a pregnancy is established, but prior to the due date to ensure that even women who deliver prematurely are sort of covered by this visit. And here we go over plans for delivery, ensuring liaison with the obstetrical team, scheduling of postpartum care. Once women actually deliver and are caring for the newborn, it may be harder for them to actually plan the visits that they need to take care of themselves. And therefore, as much as these can be scheduled in advance and possibly changed if there are any either prematurity or unexpected outcomes with the pregnancy, this will help the mom actually stick to her schedule and stick to her self-care. So postpartum care would involve an MRI, scheduling therapy appointments if needed, and sort of having a general plan about the treatment. And then exploring the woman's approach and preferences regarding breastfeeding and treatment postpartum. Finally, 2 or 3 months postpartum, and sometimes even earlier, within 4 weeks postpartum, a postpartum visit to assess for peripartum depression, rehabilitation needs, sleep fatigue, social support. Consider a surveillance MRI, again, to see if anything has changed in the postpartum period, and to talk about DMT resumption. So in this first pre-planning visit then, we have a couple questions to answer from the patient. The first is, can MS affect fertility? There's no clear signal of reduced fertility. That said, there may be some mechanisms by which women with MS may have individual increased risk of reduced fertility, and that may be some women may choose to have fewer children knowing that they have MS. They may have decreased libido or sexual function. Hormone levels could be altered, and there may be amenorrhea from therapies, especially therapies that were used more commonly in the past. How does childbearing affect long-term MS course? So most studies have revealed, have shown no evidence that childbearing has any deleterious impact on long-term disease progression. In some studies, some women have actually appeared to have less progression. There are possible confounders like age at onset of MS and also reverse causation, whereby women who have less severe disease may who have more severe disease, or even prior to MS onset who have prodromal disease, may opt not to have children. And further studies are actually required to confirm whether it may be beneficial, but there's certainly no major evidence that childbearing negatively impacts MS in the long term. What are the effects of MS on pregnancy and the newborn? There's no consistent evidence of a connection between MS and major risks of either pregnancy loss, stillbirth, fetal malformations, low birth weight, or prematurity. There may be some increased likelihood for an operative delivery, and it's not clear whether that reflects clinician preferences or clinician-patient decisions based on perceived severity of the risks of the delivery. We do recommend communication between the MS clinician and the obstetrical clinician to sort of harmonize knowledge and planning. So what are the effects of childbearing on short-term MS course? So this is a now classic slide that shows that relapses during pregnancy, so in the gray box, decrease relative to prior to pregnancy, and then rebound again after delivery. This observation has been reproduced in many different cohorts in many different countries. It's also been suggested, and again, reproduced in many cohorts and in systematic reviews, that exclusive breastfeeding may actually decrease the risk of that postpartum rebound. However, in the DMT era, this picture gets a little bit more complicated, where we're actually seeing increased relapses during pregnancy in women who discontinue fingolimod or natalizumab, both of which are associated with sort of a post-discontinuation rebound. And so it's important to think very carefully about when and how to stop the medications in this group of women. Assisted reproductive techniques, even though women with MS may not experience infertility at higher rates than other women, ART does account for many live births in developed countries. And in a meta-analysis of 5 small studies, we did find an increased risk of relapses or MRI activity after ART cycles, especially unsuccessful cycles. GnRH agonists may have an increased risk relative to GnRH antagonists, although we saw relapses in both groups. These studies could not account for effects of DMT interruption or of either the stressors or the hormonal effects of pregnancy loss. In most recent cohorts, some of which are still at the conference level and not yet presented in manuscripts, we don't see the same increased relapse risk. And it may be that women today are continuing DMTs through this very potentially protracted and stressful time period, and that DMTs may protect against this elevated risk associated with ART. Again, this is a key time for coordination of care between the fertility experts and the neurologists or other MS providers. When to stop the oral contraceptives. So many of our women may be on oral contraceptives, and the situation we want to avoid is a situation where they stop their MS therapy and then they stop their oral contraceptives, and it takes them a while to resume normal ovarian function and be able to get pregnant. And so for that reason, it's important to stop the pill and to start barrier methods. And once those cycles normalize, then to stop the disease-modifying therapy and continue mechanical methods until the decision, until the washout period has ended and the decision is made to start trying to conceive. So then on to one of the more critical questions, when to stop DMTs. So a general principle of teratogenicity is if a patient wants absolutely no drug on board during a pregnancy, then the washout period must be 5 maximal half-lives. And this is based on exponential decay of the drug to ensure no drug on board at the time of conception. And here the caveat would be paraflutamide is an exception because an accelerated washout protocol is recommended by the manufacturer. And also, fingolimod and natalizumab have the rebound risk, and so we would do things a little differently with those 2 drugs. That said, in many cases, again, going back to the principles of shared decision-making and individualized planning, we actually could consider continuing some medications during pregnancy if the benefits exceed the risks. And so this applies particularly to the self-injectable therapies, so glatiramer and interferons, where there's just no major signal of adverse effects of these medications during pregnancy. And so large cohorts now of women treated in the real world have just been very reassuring. And so many centers now and many clinicians and patients are deciding to just continue these self-injectable therapies throughout pregnancy. Orals, to date, the data are not as reassuring, and those should not be continued during pregnancy. Infusibles are a more mixed picture. So ocrelizumab and rituximab, to date, there is no major signal of adverse effects, but it's important to check lymphocytes and B cells in newborn cord blood. Natalizumab, again, there's no major signal of adverse effects on the pregnancy, except for hematologic alterations in the newborn. So if the decision were made to continue natalizumab, it would be reasonable to continue with extended interval dosing, with a last dose around 34 weeks of pregnancy, and then to check the CBC in the newborn. Alemtuzumab could conceive after the final infusion. We recommend close monitoring off DMTs in the women who discontinue DMTs prior to conception. And if there's a particularly high risk of relapses, so in a woman who has had a lot of breakthrough disease, you could consider monthly steroids timed to the menses from the point of DMT discontinuation all the way to the conception and a positive pregnancy test. And could also consider bridge therapies in women who are discontinuing natalizumab or fingolimod. What do we mean by that? This is just the accelerated washout protocol for the teriflunomide. One option in terms of bridge therapy are B-cell depleting disease-modifying therapies such as ocrelizumab and rituximab. And in this situation, let's take our patient as an example again. If you discontinued fingolimod and treated her with an anti-B cell therapy, the B cells will be out for at least 6 to 9 months, if not longer. We see protracted depletion of CD19 cells, but the medication would also be out within about 2 to 4 months. And so if conception were timed to when the medication is eliminated from the system, then you have an extended period of time where the woman is protected from inflammatory events, but also has no drug on board and can conceive safely from that respect as well. We do in women for whom we use bridge therapy, we do recheck their B cells at 6 months from prior infusion, and then every 6 weeks or so to ensure their B cells are still depleted if they're continuing to attempt to conceive off of DMT. So what are our other options for this patient? Certainly to date, continuing fingolimod is not advised, given potential risks to the fetus. Discontinuing fingolimod and crossing figures, again, could result in rebound activity. Steroids could potentially mitigate the impact of rebound activity, although not fully, or the woman could consider a bridge therapy. So what about MRIs during pregnancy and breastfeeding? During pregnancy, there's no evidence that MRI is associated with fetal harm. It's recommended to avoid gadolinium unless it would absolutely change management for the patient. So typically, in order to avoid having to give gadolinium during pregnancy to determine whether a relapse or a neurological symptom is associated with a new lesion on the MRI, you can actually obtain an MRI without gadolinium as long as you had a baselining MRI prior to the pregnancy to compare it to, so that you would know that any new lesion during the pregnancy MRI is new relative to the pre-pregnancy baseline. Breastfeeding, gadolinium excretion in breast milk is low, as is absorption to the neonate's gut, and it's actually considered compatible with breastfeeding. So during pregnancy, how can we try to prevent relapses and or treat them? It's important to consider the risks of a relapse versus the risks of therapy. And so options for treatment or prevention if a woman is going through pregnancy without DMTs are monthly IVIG or monthly steroids. These should be done after the first trimester. And to use prednisone, prednisolone, or methylprednisolone because there's minimal fetal exposure with those. And no betamethasone or dexamethasone unless they are indicated specifically to promote fetal lung maturity. Symptomatic treatment during pregnancy. So women may have exacerbation of their MS symptoms. Typically, they report that this is a time where they feel quite well, but should they experience fatigue, mood changes, bladder changes, spasticity, headaches, or pain, you may be called on to manage those. And I typically recommend aligning your therapeutic decisions with the obstetrical provider because there may be differences in risk tolerance between neurologists and obstetrical providers, and we want to ensure consistent messaging for the patient. So back to our patient, she does opt for an anti-CD20 bridge therapy. She conceives 4 months later, delivers a term child, has the cord blood analyzed for lymphocytes and B cells. And so now she wants to breastfeed and she's fearful about postpartum relapses. So let's move on to the postpartum period. So deliveries, in most cases, it's the obstetric needs that guide the mode of delivery. There may be a slightly higher risk of induction, progression of second stage of labor, or use of forceps or operative delivery in women with MS. Again, it's unclear whether that's clinician preference, patient preference, or whether that's as a result of any obstetrical complications. Again, the choice of anesthesia depends on the delivery mode. There's no evidence that anesthesia type or delivery type affects MS at 1 year postpartum, and there's no evidence that women with MS may have extended duration of hospitalization. The unknown here are that women with more active or severe disease are understudied. So general postpartum care, again, getting a surveillance MRI because women may have new lesions that are not clinically apparent in the postpartum period, counseling around return to work, familial and social supports, figuring out who in a woman's life can help with chores, who can help with a sleep routine, giving her a break or a nap during the day, and then assessing function. So balance, strength, endurance. Does she need a PT referral? Bladder, does she need a pelvic floor PT referral? Sleep schedule, and then also mood. About 20% of women in the general population experience peripartum mood changes, and the rate in MS is unknown. That's likely to be higher given that pre-existing mood disorders can predispose to peripartum mood disorders. And we know that individuals with MS have higher rates of depression and anxiety. So breastfeeding. So this is one of the key topics in the postpartum period. The WHO recommends 6 months of exclusive breastfeeding. There are many pros that we all know to breastfeeding, such as benefits for the infant, benefits for maternal physiology, mother-infant bond. It also looks like breastfeeding offers protection from relapses, something I alluded to earlier. There is broad cross-cultural variability in breastfeeding practices, both duration of exclusive and semi-exclusive breastfeeding, and then the intensity of suckling and or pumping. But a meta-analysis looking at breastfeeding across many studies suggested that it halved the likelihood of postpartum relapses, and this has been reproduced in several more recent studies as well. There are possible confounders here that women with aggressive therapy may choose to resume disease-modifying therapies earlier, and there may be sampling error, but all in all, the majority of studies are now really moving us to consider that breastfeeding has real benefits for the postpartum woman with MS. So if a woman does not plan to breastfeed, then the management options are fairly simple: to restart highly effective therapy within 2 to 4 weeks postpartum. And if she continued disease-modifying therapy during the pregnancy, either continue that one or switch to a more effective one. If she plans to breastfeed, options include breastfeeding exclusively and then a rapid wean and restart of disease-modifying therapy, breastfeeding exclusively with monthly steroids to help reduce the risk of postpartum relapse. There are ongoing studies in that area, and then rapid wean and restart the therapies, or breastfeed and potentially restart therapies. And in any woman who chooses or plans to breastfeed, we do recommend lactation support in order to optimize her ability to do so. So the field has really changed in terms of whether or not to treat a woman with DMTs during breastfeeding. And this is a recent review by Dr. Lerner Gould. And the factors that influence the risk and benefit of DMTs in breast milk include whether there's a higher or low likelihood of transfer into milk. So there's a higher likelihood with smaller molecules or low protein binding. What the bioavailability of the drug is once it's in the milk, potential effects of exposure, and we really need more data from milk samples and also from newborn outcomes. And so in this model, it's reasonable to continue or to start self-injectable therapies while breastfeeding. It's recommended to avoid the oral molecules during breastfeeding, and it's reasonable to consider treating with monoclonal antibodies. So we'll review the monoclonal antibodies, IgG transfer into breast milk. And so after colostrum, so about 7 days postpartum, only large IgG molecules enter breast milk. There is a formula, relative infant dose, that's calculated that determines how much of the mother's dose the infant would see. And we'll go over the RID with a couple drugs. And then there's also the consideration of this very low absorption of IgG molecules by the infant then. The RID that's typically considered acceptable is less than 10%, caution 10 to 25%, and definitely unacceptable after 25%. So these are recent data that we just published on rituximab in breast milk. We had 4 women with MS and serial samples of breast milk, as well as several other additional women. And what you can see are actually there's a peak within typically 48 hours post-infusion, and then you see a decline in the concentration of the breast milk, concentration of rituximab in breast milk. Here you see a second peak from the second infusion. The woman received 2 doses split in half 2 weeks apart. And again, you can see from rituximab infusion, the early peak and then decline to very low levels over time. Overall, the concentration was very, very low, and the mean RID was 0.08%, so definitely less than 10% considered acceptable. These patterns have been found in many other monoclonals as well, many that are used for gastrointestinal or rheumatologic disease. Unknown still whether alemtuzumab or ocrelizumab are found in breast milk, although we have an ongoing registry for ocrelizumab. And to date, that newborn outcomes at 1 year for exposed newborns have been reassuring. A caveat for IgG monoclonals, so in this case, natalizumab, there are slightly higher concentrations of these drugs found in breast milk, still below the RID. There is also a concern that repeated monthly dosing may over time bump those levels up, although they appear to date to still be within acceptable limits. So what do other disciplines do for monoclonals in breastfeeding? The American College of Rheumatology does recommend to continue rituximab and TNF inhibitors. And the American Gastrointestinal Association notes that biologics can be continued during breastfeeding. So again, this is always a personalized, individualized decision. What are other options? So for mothers who delay DMT resumption for breastfeeding, or who are restarting a DMT with lower efficacy or slower onset of action, you could again consider monthly steroids. Again, there's ongoing work in this arena to really try to determine true effectiveness here. And then also IVIG monthly. This has been reported in several studies. It is expensive, there are more risks, and more recent reports have not confirmed efficacy. This is a slide that looks at steroids in breast milk, and it shows, again, a peak and then a rapid decline within hours after infusions of intravenous steroids, and it suggests as well that methylprednisolone may be also compatible with breastfeeding. And it may not be required to recommend that women pump and discard their milk after infusions. So back to our patient. So her postpartum course, she opts for an anti-B cell therapy. She weans her infant. She's clinically stable at the 9-month postpartum checkup, and the newborn appears to be growing well and with milestones on track. So just key takeaways about pregnancy and MS. In the majority of cases, women with MS can safely choose to become pregnant, to give birth, and to breastfeed healthy children. There is a need for proactive and interdisciplinary management of women of childbearing potential. And this includes planned follow-up at key transitions, pre and post-pregnancy. As a rule of thumb, except teriflunomide, if you want no drug on board, discontinue the medication 5 maximal half-lives before conception attempts. There is a risk of relapses associated with fingolimod and natalizumab discontinuation. In addition to general health effects for the mother and the infant, breastfeeding may reduce the risk of inflammatory activity postpartum, and there's need for better studies of women with MS in the peripartum, certainly around symptoms such as mood, but also because more recent studies have suggested that not all women may experience that postpartum rebound. And it's important to see how women do as the treatment landscape evolves and as our ability to detect MS at an earlier time point evolves. So some special situations. The first is children of parents with MS. We're sometimes asked, what's the impact of parental MS on a child's development? It is true that there is an increased risk of developing MS if a parent has MS. The modifiable risk factors here during childhood and adolescence may be vitamin D levels, avoiding smoking, and maintaining a healthy body weight. Obviously, what's not modifiable currently are the genes themselves or exposure to EBV. In terms of development and coping, children whose parents have MS develop a good, strong empathy skill set, and their early childhood development does not seem to be affected by parental MS. The exception could be parental mental health. Parents who have untreated mood disorders could have children who also suffer in terms of development. What about COVID-19? This is an emerging situation. What we don't know yet is how much of the virus can actually pass to the fetus and pass to the breast milk in sick mothers. And it's not known also, given sort of just the pattern of this rapidly changing pandemic, whether it increases the risk of preterm birth. What we do know are that behaviors such as hand washing and physical distancing are very critical in our pregnant women with MS. Opting for telemedicine when possible to avoid potential hospital acquired exposures, paying attention to maternal or the pregnant woman's mood, anxiety, sleep, safety at home during shelter-in-place restrictions, and exercise during shelter-in-place restrictions, and also really managing the comorbidities. Obesity, diabetes, high blood pressure are all in general detrimental to pregnancies, and specifically detrimental also to resilience against coronavirus. The American College of Obstetrics and Gynecology has updated resources on their webpage as well. What about fathers with MS? There's very little data about them. There's very little data about fertility. They may, men with MS may suffer from hypogonadism, but it's not sure to what extent that's a consequence of having a chronic condition versus hypogonadism actually predisposing men to MS. Birth outcomes, one study showed no association between paternal MS status, disease duration, disability, and either birth weight or gestational age. There are very few studies of DMTs. The accelerated washout protocol is recommended for teriflunomide in men if they're planning to have a child. And it's important to also pay attention to men with MS as they become fathers, to explore their satisfaction with parenting, their perceived limitations, and also their perceived impact on their child. Neuromyelitis optica course, this is a condition where the risk of relapses increases both during pregnancy and postpartum. There are ongoing studies, emerging evidence of the importance of treating women with neuromyelitis optica spectrum disorders during pregnancy and postpartum. And again, anti-CD20 therapies may be helpful here. So we've managed our patient through her pregnancy, and so now we're going to move on to menopause and the years beyond menopause. So here's our third patient, the 51-year-old woman with MS who comes to the clinic because she feels trapped. She has had MS for over 20 years. She has a high body mass index. She has a low disability level, but mild trouble across a number of functional domains. She reports that she's experiencing menopausal hot flashes, and these are bothersome. They worsen her sleep and her MS symptoms. She has more difficulty keeping up as a part-time school librarian. She's also experiencing empty nest syndrome. Her husband took early retirement, and his continuous presence at home is frustrating to her. So her questions are, is my MS getting worse? Do I have dementia? Am I going crazy? And would hormonal therapy help me? So menopause, an overview. So the final menstrual period is the period beyond which no menses occur for 12 months. And so a woman is defined as being, as having gone through menopause once she is a year out from her final menstrual period. There is a menopausal transition. There's an early menopausal transition characterized by changes in the menstrual cycle as well as hormonal changes. A later perimenopausal transition, and then the early and the late postmenopause years. And so it's important to note that the menopausal transition is really just a few years in the normal patterns of aging. The vasomotor symptoms, so the hot flashes that are sort of the hallmark of menopause in Western countries, are most likely to occur in that early postmenopausal time point. Menopause coincides with the median age of women living with MS. So it's true that women develop MS in their 20s and 30s most likely, but women living with MS are the median age of women living with MS is closer to the age of natural menopause. It also coincides with disease progression in historical cohorts where we really saw an acceleration of disease progression around the age of 45 or 50. So we'll talk a little bit about menopausal age in women with MS, menopausal experience, and then how to think about postmenopausal progression. So in 2 MS cohorts, we found that the age at natural menopause was just right on track with women without MS, suggesting that MS doesn't affect in any way a woman's overall reproductive lifespan. We also found worsening of MS disability after menopause, both on a self-reported scale and also on the expanded disability status scale, sort of classical disability scale in MS. And when we followed women with MS through their menopausal transition, we did see that their EDSS tended to worsen at a more rapid rate after menopause. This has been shown also in an Italian study where EDSS score did seem to increase more rapidly after the final menstrual period. There may also be a possible decrease in relapse risk. So where the risk of relapses, annualized relapse risk, actually tends to decrease after the final menstrual period. That observation was also reproduced in a separate study. So what are the mechanisms here? There may be general aging mechanisms, so immunosenescence, changes in the immune system with aging, and reproductive immunosenescence specifically. There may be changes in mitochondrial function, in cardiovascular function, in cell turnover. It's also unknown to what extent ovarian hormones themselves exert protective effects on the mechanisms listed above, or whether they actually have specific effects on myelin repair as well. Certainly anti-Müllerian hormone, which is a marker of ovarian aging, is highly associated with a declining brain volume in patients with MS, suggesting that mechanisms of aging in certain cells, such as in the ovaries, may coincide with aging in the central nervous system as well. So what is the experience of women with MS who go through menopause? We did do a qualitative survey here to try to understand some of these, and they talked about the impact of a perimenopausal onset of MS in some cases, the effect of hot flashes on their MS symptoms, an overlap of MS, menopausal, and aging symptoms, which we'll come back to, worsening of MS-related disability after menopause, especially when that menopause occurred early and was surgically induced. And also they had mixed reports on the effect of hormonal therapies on MS symptoms. So just to explore these overlap symptoms a little more, there are many. So at the time of menopause, women may experience a worsening in a number of symptoms: mood, sexual function, sleep, fatigue, bladder. Those are, of course, symptoms that we'll recognize that are common in patients with MS. Additional overlap between MS and aging are things like infection, pain, ambulation, sarcopenia, vision, and altered risk benefits of disease-modifying therapies. With general aging come the comorbidities such as cancer, hypertension, and smoking. And life changes for women both around the time of menopause and with aging are perhaps changes in their career, perhaps changes in their marital relationships, and also perhaps emptiness, changes in the family household composition. The bright spot seems to be relapses that may decrease post-menopause, and heat sensitivity from the vasomotor symptoms may be particularly bothersome to women with MS. So what are the general principles of management? Rather than paint this as a very negative picture, it's really important to focus on opportunities. So what is the opportunity that we have at menopause to really set women up for a healthy trajectory as they age? And so it's important to frame it positively. And this may be a time where we find that seeing patients more frequently allows us really to dig a little deeper into their symptoms and function and really ensure that we have a good handle on preventing worsening of disability progression after the final menstrual period. So one key conversation topic is to revisit disease-modifying therapy. So in some cases, it may be worth intensifying DMT and to focus on subclinical inflammation and potentially silent progression. On the flip side, there may be declining effects of the DMT on relapse prevention as the risk of relapses decreases in the postmenopausal years. And one caveat that we have here is that most DMT studies have really only included patients up to age 50, sometimes 55. And so this is still a really gray area in terms of the need for real world evidence to guide how we counsel our patients in the postmenopausal time period. Intensive focus on symptoms and function, so rehabilitation, symptom management, and then planning for healthy aging, assessing bone density, the comorbidities, the other really important components here. And potentially vasomotor symptom management may improve quality of life, as it has been shown to do in the general population, as well as some of that fluctuation in the MS symptoms that patients report in that early postmenopausal time frame. Finally, discussing meaningful quality of life and priorities with patients. We may not be able to get a handle on all their symptoms immediately, and there may be some losses of function that are unavoidable. And so it's important to really focus on the functional aspects that are the most important to our patients and to really try to target those first. And this could involve social work or family therapy as well. So just to go through a couple of the symptoms that women experience at menopause, I will go over just the general manifestations and approach to therapy, but the slides do provide a little more detail here. So the vasomotor symptoms manifestations include both the classic hot flashes, but also cold flashes, blood pressure changes, and the sensation of a rapid heartbeat or a power surge. They have an effect on MS through a number of mechanisms: sleep disturbance and insomnia, directly exacerbating symptoms due to heat sensitivity, and also potentially leading to pseudo flares or exacerbations that must be disentangled from true new inflammatory events. In terms of medications, hormonal therapy is considered the most effective therapy, but in women for whom hormonal therapies are not advised, there are a number of other options. And this is a key thing, a key message for counseling is that if hormonal therapies are not advised, that's not a reason to ignore the symptoms, because antidepressants have been found to be effective at controlling vasomotor symptoms, other medications as well. And finally, there's a very strong placebo effect in all menopause trials that can actually be leveraged to encourage women to think positively about their future. There are a number of lifestyle accommodations as well. Sleep is a clear symptom that can worsen at menopause. It's important to identify and assess the various triggers, which are many. Consider counseling and or sleep consultation surrounding sleep hygiene and potentially evaluation for sleep apnea. And then there are a number of interventions, pharmacological as well as lifestyle. Mood, again, frequent overlap at menopause, especially late in the perimenopause. There are a number of life changes going on for women, and we know that people with MS have a higher prevalence of anxiety and depression that may be underdiagnosed and undertreated and may manifest at the time of menopause. Depression can influence the severity of other MS symptoms and their perceived severity. And so we really recommend a multi-pronged approach here that can include psychotherapy as well as antidepressants, support groups, optimization of fatigue and sleep and other triggers, and possibly social work as well. Cognition. So with menopause in general, women may report changes in cognitive function, especially in that first year after the final menstrual period. It's well known that patients with MS experience some degree of cognitive impairments. And so neurocognitive testing may help to identify particular areas of dysfunction. Cognitive rehabilitation may be helpful as well. There's increasing evidence of the positive effect of cognitive rehabilitation when it's targeted to specific domains. And it's important to address, again, the other contributors here, sleep issues, fatigue, mood, and pain that may be worsening perceived cognition. Fatigue, again, a strong overlap between menopausal symptoms and MS symptoms. In addition to the sort of other contributing factors, it's important to rule out potential thyroid disease in this population. Maintaining a daily schedule where the work routine is spaced out, where there are planned breaks, and maximizing the more burdensome activities in the cooler morning may all help manage fatigue. Mind-body techniques may be helpful as well as pharmacology. Osteoporosis. So after the menopause, women in the general population are at increased risk of fractures, morbidity and mortality from osteoporosis. In MS, this may be specifically so, potentially through the use of steroids, especially in women diagnosed sort of pre-DMT. There's sedentarism and deconditioning that may be contributing, potentially low vitamin D. And then if women do have osteopenia or osteoporosis, impairments in balance, vision, strength, or cognition could actually worsen gait issues and compound the risk of falls. So here, there are behavioral strategies. Fall precautions is key. So considering a home safety evaluation, physical therapy for gait, and also making sure that there's an up-to-date vision assessment. Encouraging regular bone density testing with the PCP. This is one of those areas where, as neurologists, it's not our primary role to recommend which type of therapy to give in a woman who has osteoporosis or osteopenia. However, it is our role to advocate that they be evaluated. And I'll get back to the diagnostic neglect, but we can play a very important role in reminding PCPs and internists about the specific risks in our patient population. Hormone therapy. So there are several types of hormone therapy, both estrogen therapy as well as combined estrogen-progesterone therapy. The therapy can be delivered both orally, vaginally, or transdermally. There are a number of documented benefits to hormonal therapy for vasomotor symptoms, bladder and gynecological symptoms, bone health, libido, quality of life, and there are some risks as well, including cancers. It's important to note that the perceived risks and benefits of hormonal therapy have really changed. It was perceived to be very beneficial prior to the nurses' health, during the nurses' health study days. The Women's Health Initiative really increased our concern about risks of the therapies. And since then, we've really seen, when re-examining the data, that women treated within a few years of their actual menopause experience the benefit of the hormonal therapy, and that it wasn't felt to increase the risk of stroke or heart disease in that patient population. What do we know about hormonal therapy and function in MS? We know very little. Most of the women who have been observed in observational cohorts in recent years went through menopause without hormonal therapy because this coincided with the post-Women's Health Initiative years and guidelines to avoid it if possible. So we looked at women, at physical function and women with MS who were treated with hormonal therapy in the nurses' health study, and we found that women who took hormonal therapy at the time of their final menstrual period were in better physical function in the years following their menopause, and that the duration of use of the therapy was associated with better function as well. That said, when we looked at those same women prior to their final menstrual period, even before they started hormonal therapy, the women who went on to start hormonal therapy were already doing better. And what this suggests is that women who were in better physical function were more likely to go to their doctor for their menopausal symptoms and were more likely to receive hormonal therapy. So rather than suggest that the hormonal therapy definitely improves physical function, it's more likely that the women with better physical function received the hormonal therapy. And so there are still large biases in observational data, and more studies are needed in this area to understand whether hormonal therapies are protective in any way against MS disability progression. A practical approach, how to manage the possible benefits of hormonal therapies for vasomotor symptoms, for osteoporosis, for quality of life. We recommend an individualized approach, close communication with a primary care doctor, and if using hormonal therapy, treating the symptoms with as low a dose as possible, as short a duration as possible. Again, it's not our role to prescribe these therapies, but it is our role to consider how they might help our women with MS. And then general considerations about aging well. So again, if we think back to the slide on reproductive aging, the early postmenopausal period is really short. But then as human beings, we have a long period of longevity after the final menstrual period. So if that's typically at 51 years old, women live for many decades beyond that final menstrual period. And so again, the menopause is a key time of opportunity to set our patients up for healthy living beyond that time period. And so managing the comorbidities, smoking, blood pressure, heart disease, and MS, these correlate with disability, and they also may influence our choice of disease-modifying therapies in the future, managing the depression and anxiety that our patients may experience. Medications, to think about dosing, interactions, and side effects, for example, anticholinergics, trying to minimize their effects on cognition. 2, put an emphasis on support and coping, friends, peers, spouses. These are strong sources of support in patients with MS and may sort of help protect them against adversity. And so it's important to really rethink these relationships and these sources of support around the menopausal transition. And then to bring up the concept of diagnostic neglect. It's been shown many times that women with disabilities are less likely to be up to date on Pap tests, mammograms, and other recommended age-appropriate screening. And the disparity seems to be worse for women who have worse limitations. So the analogy would be they may have a lower cancer risk, but a larger tumor size at diagnosis. And so for this reason, it's really our role as their MS clinicians to make sure that their age-appropriate care is up to date. So back to our patient, her questions. Is her MS getting worse? After menopause, we may see some worsening of function. Overall, it's a slight worsening of function. Is she going crazy or developing dementia? Probably not, but we can help manage her symptoms through this transition and minimize the morbidity. Would hormonal therapy help her? It could help the vasomotor symptoms, and it could be recommended at a low dose with careful monitoring. Other recommendations for the patients are to intensify symptom management, intensify the management of comorbidities, consider formal weight loss and exercise programs given that her BMI was elevated, focus on quality of life and also purpose in life, and hot flash management may help stabilize her symptoms. So this is the end of the presentation. There are many underexplored areas of research and care involving women at all reproductive stages, and the evidence does continue to change, and therefore we hope that there will be many more studies that contribute to our understanding of how to best optimally manage our patients in the future. I thank you for your attention, and again, thank the CMSC for their invitation to participate in this program and also their hard work in making this feasible despite the circumstances.